So you guys, we only have 20 minutes and clearly there's tech problems. Can you guys keep working on it? I will just continue to talk. Hopefully we'll get our slides up so you can actually see the 5 articles we're talking about. I'm Jeanette Wolf. I'm from Bay State UMass Chan. This is Basma Safdar. She's from Yale. I have no financial disclosures to disclaim. Basma's big crap. She does.
A few grants from NIH and CDC.
So our objectives today are to make you think about how biological sex and gender influences healthcare outcomes and how we want you all to practice up-to-date science. So there's some really beautiful slides that are not showing up right now, so we are just going to wing it because we are emergency medicine physicians and that's what we do. So the first slide, the objectives of this talk is we're going to go over 5 articles. We're going to go over the Sager criteria. If you take away one thing, we want you to learn about the Sager criteria and take it back to your organization. The Sager criteria is adopted by the WHO, and it's really simple stuff. It's all about sex and gender and research and equity, and it essentially goes, if you are doing a study that has only male patients in it, here we go. Yay. Thank God, I spent a lot of time on these beautiful slides. Thank you. So does anybody feel like this right now in academic medicine? So I think if you study sex and gender, there's probably a few more holes in there, right? Because it's been really hard to talk about things that influence patient outcomes and a really trying atmosphere. But here's the deal. We need to find that beacon. We need to find that light that we follow and remember that our core values are that we practice up-to-date science. And that we do this because we want to optimize the most for the most patients. So what do we know? We know at a biological sex, chromosomes, hormones, it influences how our physiology and our pathophysiology works. It influences if we get sick from certain toxins, if we get sick from certain infections, how we have heart attacks. But we also know that how we live in this world, how we present ourselves, what expectations, what experiences, and what exposures influence our healthcare outcomes. As we spoke earlier, 95% of truck drivers are men. That influences what happens to them. These are the guidelines. One thing from this lecture, take it home and use it in your journal clubs. There is a lovely article by Angela Jarman about how to use these guidelines in your journal clubs. And it's really simple, common sense stuff. Who's in the study? If you're reading a study that only looks at male animals or only is about females, you should say it in the title. What do we know about the prevalence of the condition? If you're talking about migraines, 75% of the time, you're talking about females. If you're talking about Brugada syndrome, more than the majority of the time, you are talking about males. In the methods, have you looked at biological sex as an independent variable? In the results, have you disaggregated your data? Now, if your study is not powered for biological sex, when you disaggregate your data, you get information that can go to your next study. Importantly, when you guys are reading studies, when was the last time you ever thought about the sex of the person who dropped out of a study? Like, we never think about that. We say 15% of people dropped out. Well, what if 90% of those 15 were one sex, male, or if they were female? And for the purpose of this talk, we are talking about, because these studies are on biological sex, we're talking about males and females. There's not information about intersex people. So here are the papers I picked. We picked 5 papers. Each paper we picked for a specific reason and a specific take-home point. This is the first one. This is Sex and Gender Reporting in UK Emergency Medicine Trials from 2010 to 2023, a systematic review. The NIH system, they have a system of how they do their studies, and how they are funded are both private and government, and then it goes through the regulations and their IRB. So what they did is they looked at all studies that were geared towards trauma in emergency medicine, and they looked to see the simple question, how many times was the primary outcome disaggregated by sex? So why did I pick this study? Because it's this is our sandbox. And in 2013, there were very clear guidelines that we should be looking at sex-specific differences, and we're looking at the current pulse. So what did we find? These are the criteria. They use the PRISMA guidelines. 169 studies, 24 met the primary inclusion. Does anybody want to guess how many of those 24 studies looked at sex disaggregated data? So take home, there appears to be opportunities here. And some of them, again, are objective criteria for improvement. Some people got eliminated from early study enrollment because they were female of childbearing age and they were giving them blood products. And they wanted to know if they were pregnant or not. And the 45 minutes for their blood pregnancy test eliminated them from a time rise from the study. So some of these things we can fix by using different technologies. But other things, we can just follow the guidelines we already have. And I would remind you, I bet there are some peer reviewers and IRB people in the room. People don't get published unless they go through these funding to pay for their study. They have to know how to journal submit. One of our friends, Dr. Hiran Shadera, who is international, she went higher up on the journal sort of totem pole and said, I can go to these individual journals or I can go to the warehouse of the journal themselves. They used one template for like 20 different journals. She changes that template and overnight she changes how things are submitted to the journals. So you all have some sort of sphere of influence in your own institutions. Use it to help your colleagues practice better science to be better advocates for our patients. So paper number 2. This is BMJ Global Health. This looked at how pandemics can be viewed through a sex and gender lens. And why I love this, as somebody who doesn't study this, it gave this wonderful sort of template of how you view pandemic global healthcare through a sex and gender lens, and it introduced this concept of integrated outbreak analysis. Now, for those of you who don't know what IOA is, and I was one of those people, there is a movement in international global health to have a stockpile of all these different points of data, so real time on the ground, you can have accurate and actionable data. So what these folks did, it says, as we're developing these cells, how can we make sure that there's a sex and gender lens to the data around a pandemic? So they did a scoping review, and to remind people, a scoping review kind of looks at the landscape. It doesn't answer a specific question. And there are some specific exclusion criteria. They're looking at low and middle income countries. These are their criteria for their searches. And specifically, they excluded 3 big infectious diseases because there's a lot of material already out on those 3 different areas. So again, telling 15,000 studies, how many of them even thought about including sex and gender in their analysis or the discussion? Only 71. And there are a mixed type of studies. And here is your money slide and why this is important. So here's the anatomy of a pandemic, the prevention. How do we make pandemics not start in the first place? Then when a pandemic's on the loose, how do we detect it early enough to get a wrap on it? How do we treat it? And then how do we recover it? And just take 30 seconds and look at this slide because it tells you all you need to know as to why it's important that we study this. So the take home from this paper is pretty simple. Pandemics are very contextual to the organism that you're being infected by. Ebola has a very different biological, sex, and social cultural influence of how it spreads and how it's contained. And we need more disaggregated data because sex and gender impacts who gets sick. It impacts who gets care. It impacts who makes the decisions at the table of making decisions, and it influences who gets treatment. And I think the last part we forget, but here's an example. If you're in a low or middle income country and your school shut down for 3 months due to a pandemic, and you are a 14 or 15-year-old girl, there is not an insignificant chance that you will become pregnant. And if you become pregnant at the age of 14, that affects the health of yourself, your family, and your community for the next several decades. So this is why this matters. So my final paper is on car crashes. And why did I choose this one? Because one of the only bipartisan bills that's up for right now is the She Drives Act. And the fundamental reasoning behind this bill is that we know that we are using outdated mannequins in current car crashes. So the average mannequin that is supposed to represent the female body currently is 4'11" and 108 pounds. And we know from data that car accidents look very different in males and females, both due to biological sex differences, but also due to gender. Again, 95% of professional truck drivers are males. Men in general drive several thousand miles more per year. They tend to have accidents with higher speeds, increased alcohol use. Females tend to be a little bit more likely to wear a seatbelt. We tend to drive older cars, and we don't tend to drive pickup trucks. Here's a pretty dramatic slide, another take-home put in your gender toolbox. This is the difference of safety equipment. Safety equipment has dramatically decreased mortalities from car crashes, but just to show what you're looking at, you're looking at the delta of this to this. That's male differences in mortality in the last many years. This is female differences in mortality. So all of those changes have benefited men much more so than women. So what this study looked at is the fatal analysis reporting system. The most important thing you need to know about this study is you don't get data into it unless somebody dies in the vehicle. And what they did is they did a dual pair comparison. Two people are in the car, one dies, the other one doesn't. And then they looked at all sorts of different controls, the person who survived, to see if the driver was killed, what's the chance that the occupant lived? And if the occupant was killed, what's the chance that the driver lived? And is there a difference in biological sex? And then they match them because the idea with the control, they're both in the same vehicle, they're both in the same weather conditions. Airbags, they changed the data when cars had updated airbags to include seatbelts for front passengers. And interestingly, the seatbelts was an interesting one because if you are not wearing a seatbelt, female and male occupants in the car, there might be more risk of secondary injury to the female from the flying male in the car. So here are the results. What you're looking at on the right side, female mortality for young women, much higher. Ironically, you could read this paper in the other way. Go to the left side, male mortality is high. Females aged 20 to 40, 20% more likely to die in a crash than a male, and regardless of seating position, airbag deployment, and the use of a seatbelt. So the take home here, this is a Thor F model on the right. She has 150 sensors on her. This is what the She Acts Drive bill is trying to make sure we put in every car so we get more data. Just as a take-home message, for some reason, women are much more likely to have lower leg injuries in car crashes. I use this is we need to be great storytellers, every one of us in this room, to move this science forward, to use our sphere of influences. We have to have a story in our pocket that this is something we talk about, not because of any political reason, but because we take care of patients and we want them to have excellent outcome. So now I'm going to hand you over to the more brilliant of us.
Thank you, everybody. And thank you, Jeanette, for providing an excellent contextual framework of why we need to have a sex and gender toolbox. So for my two papers, and in the last 5 minutes, I want to just talk about how we can translate some of the current science into clinical practice. So I'm going to focus on ischemic heart disease and how our understanding and data on ischemia phenotypes has changed. How many people here use high sensitivity troponin? Good. So one of the things that happened with use high sensitivity troponin, which was only approved by FDA in 2017 in the US, but we have another 10-year data before then from Europe, is that the diagnosis of myocardial infarction in absence of coronary arteries, MINOCA, went up. How many people have heard of the term MINOCA? Okay, so fewer people. It is one of the diagnoses of MI that we actually are seeing a whole flurry of literature on. Why? Because one, we're diagnosing more because of high sensitivity troponin, and two, because we have better diagnostic tools, not just in the stress test, but also in the cath lab that we didn't have 5 years ago. And so it is important to stay abreast because MI is bread and butter emergency medicine, and we need to know why, what's changing in that. And MINOCA is one of the diagnoses that is 3 times more common in females. And so both my papers have something to do with it. The first paper is on some of the underlying mechanisms of coronary microvascular dysfunction, which forms the hallmark of MINOCA. So what is MINOCA? MINOCA is myocardial infarction with no obstructive coronary artery. It is 3 times more common in females. It is by definition, the definition only came out in 2017, that there was a consensus definition, and it actually then changed further in 2020. So it's possible that some of your teachers have not known about it, but it is one of the contemporary phenotypes of ischemic heart disease. By definition, it is somebody who has right symptoms of MI. They have troponin that is showing rise and fall of 99th percentile. And you on coronary angiography, you have obstruction of less than 50%. So all that we know of about MI up till now has been on obstruction more than 50%. We know it's usually one big plaque. You could put a stent across it. You give all these medicines that we know so well, aspirin, beta blockers, all of that, and you can improve outcomes. We know that. It's one kind of pathophysiology that is bread and butter of MI. MINOCA is about 10% of all the MIs we see. So 1 in 10 patients you're admitting through the emergency department has MINOCA. You may not see it, but they will come back and you will say, oh, the angiography was negative. So now the next time they come, should you be treating them as an MI patient or not? And hence you should know that you can have MI without obstructive coronary artery. And MINOCA is an umbrella term. So unlike MI-CAD or MI, typical obstructive coronary artery MI, MINOCA is the first step of many further diagnoses. So when you actually do the right diagnoses, that includes, optical, so intravascular ultrasound, or you can do tomography, or you can do MRI, all these other tools that you have. You can have MINOCA from coronary vasospasm, coronary microvascular dysfunction. You can have it from coronary artery dissection. You can have something called slow flow phenomena. You can have it from embolization, microembolization of the smaller arteries, not one of the bigger arteries. And so there are a lot of mechanisms. It's an umbrella term. It's a heterogeneous disease. It is important to have some of those further diagnoses because the management changes. The treatment that is given, it changes. So from an emergency physician standpoint, it is the first time you're making the diagnosis, but also when they come back, that these are no longer, we used to think, when I was in medical school and residence, we used to think these patients do fine. They have a great outcome. Now we have data that is just coming out that they actually don't. So going back to our literature very quickly, this study I picked because they actually looked at MINOCA on endotypes. And it was a small study of 92 patients. Half of them, 2/3 of them had MINOCA, the rest were controls. And they actually did the gold standard test for coronary microvascular dysfunction, which is one of the mechanism of small artery dysfunction, which is through this, this is an invasive test that is not done routinely, even by a lot of cardiology labs in geography, unless they're actually looking at further diagnosis of MINOCA. And the most important thing they found was across all the subtypes. So these are controls. And these are all the different subtypes I talked about. The coronary microvascular dysfunction is an overriding phenomena in all of them. And what I can tell you from my own research, and that's something that we are, is under review for publication, is high sensitivity troponin is neither sensitive nor specific for diagnosing it. So we actually need better tools in the emergency department to diagnose what is already being done in outpatient cardiology and inpatient cardiology. We haven't yet linked those, but it's coming. And you have to be aware, and unless you're aware, you won't know that we have to change our practice. So looking at our take-home message is coronary microvascular dysfunction is an underlying theme for MINOCA patients. from your standpoint, what means is the patients are coming back after the first time. Look out for your hospital may be forming pathways of of these coronary function testing or these pathways, or talk to the not all cardiologists even know about it, because it's 5 years ago that we actually came up with it. So actually try to at least see which space you're in and refer them for those coronary function testing if you're seeing these patients. So that's study one. Quick study number two is something similar, which is hypertensive disorder of pregnancy. So how many people know that hypertension during pregnancy increases the risk of cardiovascular disease? Okay. And so that we kind of know and has been coming around. The literature on it's been going on for about 10 years now. What we don't know is why some of the mechanisms may be the case. And so this study was interesting because they actually looked at a population-based study of all women who had who were parents, who had history of hypertension by ICD-9 codes, who actually eventually had coronary angiogram, and they found that patients who have so about 500 patients, they compared the patients who had heart disease versus controls, and then they found, I think the money slide is this one, that the women who had pregnancy-induced hypertension during pregnancy had MI and coronary artery disease 7 years earlier than women who were pregnant and were normotensive. On angiogram, they had worse atherosclerotic disease, even at younger age, and they tended to more likely to have Menoca. So how does that change my practice? So when I'm seeing a woman in 40s and 50s who otherwise by TIMI and heart risk stratification scores would be otherwise be low risk, I now ask everybody about their symptoms from here to here, if they're any having symptoms, because I know women will describe it differently even if they're having chest pain, and I ask them about their reproductive history. So I now ask anybody, did you have preeclampsia, do you have hypertension, diabetes, any complication during pregnancy? If they had a lot of miscarriages, that are all basically telling me that they failed a stress test, a vascular stress test. And so I look at them slightly differently. It has not entered our risk stratification scores yet, but it certainly, this is some beginning of the data that is showing that their physiology is different. Eventually, if you're doing the right testing, the tools are now here and we're actually diagnosing them far more. And so the takeaway from this study was that patients, women who have history of hypertensive pregnancies, they experience coronary artery disease about 7 years earlier than women who have normal pregnancies. They have coronary artery disease earlier in their life, and they have higher risk of Menoca because we're now diagnosing it more with a higher sensitivity troponin. I will end there. I know we're a little out of time, but if you have questions, and we'll stay around if you have questions.
Thank you, everybody, for being